Good day. This is a case presentation about an interdisciplinary management of avulsed maxillary incisors. Here is the overview of our presentation. First, introduction. Second, treatment planning. Third, collaboration. Fourth, procedures and techniques. Fifth, results and outcomes. Sixth, discussion. And lastly, conclusion. Let's start by defining what we mean by dental avulsion. It is a complete displacement of a tooth from its socket in the alveolar bone. Traumatic injuries to teeth are common in kids and young adults. An avulsion is most common in the upper jaw due to fights and sports accidents. If a tooth gets knocked out, the best treatment is putting it back in its socket. This case presentation shows how important it is for different medical experts to work together when trying to put a knocked out tooth back, even if it has been out of the mouth for a while. Patient history. Patient demographic: 29-year-old male patient. Chief complaint: the patient presents with a chief complaint of avulsed teeth due to a road traffic accident in his maxillary anterior region. Initial examination findings: his upper and lower lips were swollen and cut from the accident. Inside his mouth, two of his upper front teeth were missing. The fallen teeth looked well on the outside, and their roots were fully grown.
Treatment planning. The following diagram shows the flow of treatment process given to patient from the very first day of his visit until the very last follow-up checkup. Treatment planning. On the very first visit, the general dentist conducts the initial evaluation and assessment, which obtains the patient's medical history and perform neurological evaluation after the trauma. Oral and maxillosurgeon assess the extent of soft tissue lacerations and any potential alveolar bone fractures. Endodontist, on the other hand, evaluated the avulsed teeth numbers 1-1 and 1-2 for viability, feasibility of repositioning, and potential endodontic treatment needs. On the second visit, interdisciplinary discussion and treatment planning were conducted by all dental specialists, which collaborated in a multidisciplinary meeting to discuss findings from the first visit, review diagnostic data or radiographs, and formulate a comprehensive treatment plan. The prosthodontist, on the other hand, shared insights into potential restorative options for the avulsed teeth based on the findings from the first visit. Orthodontists provide input on the optimal timing of interventions to consider occlusal factors. On the third visit, execution of treatment plan were made, wherein endodontists conducted pulp extirpation to eliminate potential sources of pain within the avulsed teeth. He then performed thorough cleaning and shaping of the root canals. This is followed by temporary putting a seal on the root canals with calcium hydroxide and glass ionomer cement to prevent any contamination. After thorough cleaning of the canal, the oral and maxillofacial surgeon addressed soft tissue lacerations and prepared the sockets for potential repositioning of the avulsed teeth. The prosthodontist advised on executed composite restorations for the avulsed teeth. After that, the orthodontist will then reposition the avulsed teeth and do splinting with the use of orthodontic wire and composite. The periodontist will then assess the bone loss and condition around the alveolar teeth, considering potential periodontal implications. Recommendations include provide insights on regenerative periodontal surgery if necessary based on bone assessment. On the fourth visit, which is the follow-up and monitoring, all dental specialists will collaboratively monitor the patient's progress during the post-operative appointments. The prosthodontist will then assign to restorative management of the fracture. Now, let's discuss the collaboration of different dental specialists in the treatment of this case. First one is the endodontist. The endodontist collaborated with the oral surgeon in order to assess the avulsed teeth, which is number 1-1 and 1-2, for positioning feasibility. They shared findings with the periodontist as well as with the prosthodontist to ensure a comprehensive treatment plan. Aside from that, communicated endodontic considerations and planned interventions with the team were also made during interdisciplinary meetings. Oral and maxillofacial surgeon. They collaborated with the endodontist in order to assess soft tissue laceration as well as socket condition. They discussed surgical interventions with the team and contributed insights and treatment planning meetings. They also share surgical progress updates and any deviations from the plan with the interdisciplinary team. We also have the periodontist who collaborates with the oral surgeon and endodontist in order to assess bone loss via CBCT. They communicate regenerative surgery recommendations and planned interventions during interdisciplinary discussions. They also share preoperative and postoperative observations, contributing to the overall treatment evaluation. Aside from that, we also have the prosthodontist who also collaborates with all specialists to understand the patient's treatment plan and needs. They participated in interdisciplinary meetings to provide insights on restorative solutions for the avulsed teeth. They also shared progress updates on composite restorations and evaluated their success with the team. Radiologists were also important, which provides radiographic images to the interdisciplinary team for joint interpretation and discussion. They shared diagnostic insights during interdisciplinary meetings, contributing to a unified understanding of the case. Orthodontist is also part of the collaboration, which advise on the optimal timing of treatment based on occlusal considerations. They communicate occlusal adjustments and recommendations with the interdisciplinary team. Last but not the least, we have the hematologists who are potentially involved. They collaborated with a dental team to ensure appropriate collection and processing of the blood for platelet-rich fibrin preparation. They shared insights on PRF preparation and application with the interdisciplinary team.
Procedures and techniques. In the extraoral examination of the patient's face, noticeable swelling and cuts were observed on the upper and lower lips. Additionally, the front part of the upper jaw was examined and palpated. When examining the inside of the mouth or during the intraoral examination, the patient was found to be lacking upper right central incisor tooth number 1 1 and upper right lateral incisor tooth number 1 2. The patient teeth 1 1 and 1 2 were preserved in a milk, and they were brought to the department after about 1.5 hours. By immersing the avulsed teeth in the milk, it acts as an appropriate substance for preserving cell life. The dentist successfully established a beneficial condition for the teeth. Milk maintains a stable pH and osmolarity, which supports the survival of periodontal ligaments, thereby increasing the likelihood for a successful reinsertion. X-ray were recommended for the front upper area of the mouth. Once the patient gave consent, the plan was to reposition teeth 1 1 and 1 2. In here, X-ray is done in order to see if there are any anomalies that can be found where the avulsed tooth came from, or to see if that area is still intact and ready for reinsertion or the reimplantation. The avulsed teeth were checked for debris and fractures and if they have still intact crowns and fully formed roots. After gently cleaning the teeth, an extraoral endodontic therapy is executed so that there will be less root resorption. After which they were repositioned and secured with a wire and composite splint. The patient was advised to keep the splint for 2 weeks. Antibiotics were prescribed and the patient was reminded about a tetanus booster. A follow-up CBCT scan after 2 weeks showed bone loss, and the patient was referred to the periodontics department. A surgical procedure was performed to regenerate the periodontal tissues, including bone grafting and membrane placement. The splinting was extended for 5 more weeks. After a total of 5 weeks, the splint was removed and a composite restoration was done on tooth 11 to repair a fracture. Follow-up appointments were scheduled and the periodontal and periapical structures remained healthy during the review visits.
Results and outcomes. After doing a regeneration of osseous defect procedure, a follow-up of 2 weeks, 4 weeks, 3 months, 6 months, and a year was done. Evaluation results revealed absence of clinical symptoms and satisfactory healing with no signs of resorption radiographically after a year of healing.
So let's now move to the discussion. In here, opting for immediate replantation of a avulsed tooth is the most favorable course of action, as it minimizes harm to the periodontal ligament cells and enhances the prospects of optimal healing without resorption. However, this scenario is infrequent due to factors such as the emotional distress experienced by individuals and a lack of knowledge with first aid procedures. Preserving the avulsed tooth in a balanced solution like milk, saline, or saliva retards the decay of cells in the root's periodontal ligament. Nonetheless, cell death in the ligament is inevitable, and immersing the tooth in a solution offers a short-term yet effective approach in managing it prior to reinsertion. Brief storage in a balanced solution has demonstrated comparable or superior healing outcomes compared to immediate reinsertion. Milk is the commonly used and suggested storage because it is easily accessible, has appropriate pH, normal osmolarity, and abundance of nutrients and growth factors. Notably, it is important to mention that drinking water can harm the periodontal ligament due to its low osmolarity. The teeth needs to be reimplanted in its natural alignment and firmly reinserted into the socket. Replanting is generally successful for most teeth when the time that they are outside the mouth is under 30 minutes. Beyond this time frame, the likelihood of tooth surviving decreases as cells in the periodontal ligament become irreparably harmed between 30 to 60 minutes. Timely execution of root canal treatments is crucial when dealing with a knocked out tooth. Injury to the tooth can lead to death of the pulp in the affected area, harm to the socket, disruptive biting forces, and potential for tooth deterioration. Therefore, both reinserting a dislodged tooth and promptly performing root canal therapy, along with necessary adjustments to the bite alignment, holds significant significance. The occurrence of pulp necrosis in the affected area frequently contributes to or accelerates the different levels of tooth resorption. During the extraoral endodontic therapy, an intracanal medication was applied, followed by the placement of a provisional filling in the access opening. So calcium hydroxide stands as the preferred choice for intracanal dressing in cases of traumatic tooth avulsion. Following the reinsertion of avulsed teeth, a prevalent issue is root resorption. This current evaluation was undertaken to juxtapose the impact of calcium hydroxide against alternative intracanal treatments and filling substances concerning both inflammatory root resorption and replacement root resorption or ankylosis in reinserted teeth.
So the root surfaces of the teeth were covered by PRF membrane, which is a blood clot prepared and optimized form that is rich in cells and growth factors and act as a natural bioactive barrier, allowing interaction with the tissues above and below it to facilitate natural tissue regeneration and healing. So as you can see in the picture above, stabilization of the avulsed teeth is at most important to prevent further damages. So using a flexible splint, either a composite or a wire splint, immobilizing the implanted tooth. A CBCT or a cone beam computed tomography scan was used to see the teeth, bone, and surrounding soft tissue of the avulsed teeth 1-1 and 1-2 after replanting the teeth to see any progress or changes. So to manage the bone interdisciplinary, guided tissue regeneration or GTR was done to allow osseous regeneration prior to soft tissue migration into the area. So GTR uses a resorbable or non-resorbable artificial membrane which keeps tissue from growing into gaps. So regenerative procedures can be used for growth of new bones, and this growth of new bones increases the height of the bone around the tooth to give support to the tooth and extends its life. So after all the procedures are done, reimplanted avulsed teeth requires the patient for continuous follow-up at interval of 2 weeks, 4 weeks, 6 months, and then a year after, and then every year later for the next 5 years to see if there's a progress of healing or if it adapted well to the socket of the tooth.
Overall, it's really important for the patient to know how to deal with the knocked out tooth and what to do. Teaching them how to take care of the tooth and keep it safe is crucial for how well the tooth can be saved. Putting the tooth back in its place as soon as possible is the best option. This helps the bone stay in good shape for possible future repairs, if needed. Collaboration between different fields in dentistry is essential for the treatment to be possible.